Welcome and thanks for joining us today on the 13th edition of our knowledge sharing series, the CCD Rounds. My name is Joe Jewell and I am the Global Director of Cities Changing Diabetes. Cities Changing Diabetes is a global partnership of cities, more than 45 cities around the world, working to prevent non-communicable diseases, particularly with a focus on obesity and diabetes and working with the most vulnerable populations. The partnership has grown since 2014 to expand globally, and we're also working with more than 200 partners around the world. Today, we'd like to revisit the topic of innovative finance models to address the challenge of diabetes, obesity, and related NCDs. As many of you have likely experienced, it can be challenging to secure sufficient funding to scale up work on the prevention of NCDs at the community level. Yet there is obviously very good evidence that interventions to improve health and bend the curve on obesity, diabetes and other NCDs can indeed pay for themselves in the medium and long term. The key question for today, therefore, is how can social impact investment help close the funding gap for action on NCDs to create healthy communities in the long run? Today's webinar builds on a series of activities that we have led as Cities Changing Diabetes, organised on this topic, aimed at learning from city case studies, understanding the theory behind social investment, and actually engaging in practical workshops to develop the investment cases. For example, last year in November, we convened a masterclass aimed at supporting 4 early-stage case studies to develop their ideas into interactive investments. We welcome participants from the Raven Indigenous Impact Foundation in Canada, Leicester in the UK, Malmö in Sweden, and also The Hague in the Netherlands. Today we have another opportunity to go for a further deeper dive. Here, our aim is to get a view into the process of developing a comprehensive prevention programme to be partly funded by social impact bonds in The Hague in the Netherlands. We also have an opportunity to hear a presentation and an update from Aarhus in Denmark, where we'll be hearing some of the initial results after implementing the first diabetes impact bond in Aarhus. So I'm delighted to start with introducing our speakers for today. Firstly, we have Rimke Vos, who is joining us from the Netherlands, and she is the Associate Professor and Programme Manager of Research from Leiden University Medical Center. And she's going to be giving us insights into the work that is going on in The Hague and how the Happy and Healthy Hague Coalition in the Netherlands has been working around this issue of designing a program and looking at how social impact bonds can actually be leveraged. Following Rimke, we'll have a presentation from Hans Ulde Poulsen, who is a special advisor to Dalberg and the Diabetes Prevention Investment Lab. He will reflect on the initial results from Aarhus after implementing the Diabetes Impact Bond. And he'll also look at some of the prospects for expanding the use of outcome-based funding models in Aarhus and beyond. So how the session will run, Rimke and Hans will first take the floor to present and some of the details of the work that they're doing to us, and then we'll have an opportunity to come back all together for a Q&A session where you can participate. Please bear in mind you have the opportunity to enter your questions throughout the session, so there should be a question mark in the bottom right-hand corner of your screen. Please feel free to enter these questions. We're collecting them as the session goes along, and so that when we come to the Q&A, we can also take questions from the audience. But first, let us hear from our first presenter, Rimke. The floor is yours.
Yeah, well, thank you, Joe, for the nice introduction. And indeed, I would like to give some insights in the process we are in now. But before I start with the process, I would like to start to give some context information of how we are organized in The Hague. I'm not sure if you can already see the slides. I think we can go to the next slide in which, in The Hague, I'm affiliated to the Health Campus The Hague, which is a partner organization of the municipality, the public health service, the primary and secondary care, mental health service, and the university. And as a program manager, I discuss with all the partners what are the health challenges we face and how can we work on decreasing health inequalities. And within the Happy and Healthy The Hague network, it's actually a larger network, including more partners who are important. Also, the insurance companies are, for example, involved, and other science or education partners. And within this network, as a campus, we are the third trusted party. And you see here some of the partners involved in the network. And if we move on to the next slide, the Happy and Healthy The Hague network aims actually to work interdisciplinary, but it is more of a governance structure that at the high level, at the board level, there is agreement that we all want to work on decreasing health inequalities. And therefore, we have some focus areas. And one of the areas is actually the Hague Southwest, which includes a few deprived neighborhoods. And we started there with a community up and a learning approach, because maybe it is familiar to some of you, or you recognize it, that before you can really work on improving health in vulnerable populations, you first need to work on involvement, trust, and engagement. So this was actually what we have done the last couple of years. Besides including the health and social domains, we also very much focused on including and involving the residents of the neighborhood, and also asking, or especially mainly asking them, okay, what's important to you? And the first projects were not really focused on health, but more on this trust building. So if we go to the next slide. But now we have trust in the neighborhood, and people participate in several projects, also actually came with the ideas for the projects. And therefore, the time is right that we can now also focus on improving health. And especially in The Hague, it is a very diverse city with several ethnic backgrounds, but also diverse in socioeconomic position. And therefore, it is important to focus on prevention in a very inclusive and cultural sensitive way. So when we arrived at this point that we thought, okay, now we want to move forward in a sustainable way, also to improve health of the people in the neighborhood, we received actually the opportunity to participate in the masterclass. So if we go to the next slide. And as Joe mentioned, we were one of the 4 participants to the masterclass. And it was really for us to get inspired. What would be possible to work on a sustainable way? Because if you all the time have projects for only a few years or a month, a few months, or 1 or 2 years finance to start a project, then everyone is engaged and happy with the project. But if you then have to say, okay, now the money, we are run out of money, so we can't continue this nice initiative, then the trust is gone again. So therefore, you have to be very sensitive about this. And that is why we want to look for more sustainable funding. And what you see here is when we were in Copenhagen, well, we had fun, of course, but we also worked hard. And we also visit the neighborhood there, and I probably pronounce it wrong again, but then Joe or Hans can mention it later on. But we visit Timbjörg, which was very inspiring for us because they also started with the community up approach. And if we go to the next slide, you see what was our first end result. So we want to focus on the people at risk for diabetes or who had diabetes with a low socioeconomic position. And we not only want to focus on health outcomes, but also on the quality of life and on health literacy and cost. So we were, of course, very ambitious. But this was very nice for us to get our thoughts structured. Because when we were back, and when we go to the next slide, we organized a meeting with all our stakeholders, with representatives of all the partners you saw in the first slide. And we discussed with them our thoughts. And what you can see here is that what we discussed there, that the outcomes were very much similar to what we thought in Copenhagen. But it is important that they also found that our thoughts were important. So we agreed upon, I think on the next slide we can see, I think a few clicks more to have it all included. Yeah, a few more, so the whole picture will be there. Yeah, what you see here again is that indeed the focus is on the people with pre-diabetes or diabetes and how to activate them. Because what we found as a challenge was that in the Netherlands, at least, it is not organized. Well, prevention of a disease is not in the insurance package. So when you identify them, well, you first want to activate them before you can refer them to an intervention, which is often for a long time because people need time for behavioral change, but this step is often too fast. So there, well, we had here some ideas already, and again, you can see as outcome the quadruple aim, which is health indicators, quality of life, healthcare costs, but also experienced given care and care. And we want to work in a community-up approach. So what we agreed upon at the end of this day was that a small group would work out a business model. And therefore, if we go to the next slide, we paid another visit last April. And this time we visit Tim Björk, I hope I pronounced it correctly, again, and had a deeper conversation over there and heard the progress they made. And they actually also mentioned that for them it was also important to first start with the trust before they could focus on a healthier lifestyle. And what they did, what inspired us, was that they looked for the opportunities where groups were already together. And that is actually where we also focus on. So in The Hague, for example, we have already mother groups, and that's a very good starting point to discuss with them how can we focus a bit more on a healthy lifestyle. And also we visit Aarhus, and what was very inspiring over there is that they showed us, and you can see it in the left picture, the upper left picture, that they were very creative in how to educate people also who were low in literacy. So not health literacy, but also in literacy in general. And then, well, immediately we had a lot of inspiration. So we used the whiteboard. And I think if we go to the next slide, you see a bit more in detail what we wrote on the next slide. So on the whiteboard. So next slide, please. Yeah, thank you. So indeed, what we decided was that where we want to focus on is actually on identifying people at risk for developing a chronic disease. And I think if there is another click, you can see the first. Yes, there are indeed a lot of people not are unaware of their risk for a disease. But then what I mentioned before is that for them, the step from becoming aware of your risk to immediately be involved in a program of 2 years is a big step. So there's actually a window of opportunity. And another window of opportunity, if you click again, is actually because a GP who was also participating in actually all the visits and the meeting in the Netherlands, she started a group consultation where those people, after they were identified, came together and discussed with a lot of experts on which area they want to focus, because you have to prioritize, of course, where you want to start. If you want to start with weight, or if you have financial problems, and so on. But then, of course, if you identify the appropriate intervention, you want to follow them up. You want to see if they indeed go to the intervention and if they stay there. So if we have another click, the other window of opportunity is actually how can we make the people to complete the program. And then the fourth one, if we click, is actually how can we motivate them to sustain a change healthy lifestyle. And this is actually where we work on now. So if we go to the next slide, we try to find all the figures, how many people would be involved, and also where are the vulnerable spots. I think I pointed out in the last slide, but where are the vulnerable spots in the process, and how can we make sure that healthcare professionals collaborate and communicate, and that we can help this vulnerable population actually to activate them and motivate them to change their lifestyle. And for some, it might mean that they first start with support in their financial situation, for example. And indeed, the last slide, I hope you can see it, is the key milestones we're going forward. It's actually how we can combine all these initiatives to make a very nice process in which we can follow up the participants, and also further work on our business model. And this week, at the end of this week, we will discuss the first steps we made with our stakeholders, and we hope we can move onwards with it. And if everything goes right, by this summer, we will have a business case, and hopefully then at the end of 2023, we can start.
Thank you so much, Rimke. That was a great presentation, and really exciting to hear a really practical example, an example from on the ground of how you and colleagues in partnership are looking at how you can make this sort of thing work on the ground in a community. I'm going to move directly onto the presentation from Hans, but I'm looking forward to welcoming you back for the Q&A, Rimke, where we can get into a little bit more of the detail. Hans, the floor is yours.
Thank you, Joe, and thank you, Rimke, for another good presentation. Always good to hear how you are progressing in the Netherlands. So I'm here to present some experiences from Aarhus, and what I want to do with this presentation is to take the Aarhus case, the investment program that we made in Aarhus, and put it into a slightly bigger picture. Because I think that's one thing that is very crucial to me to say today. And I think when you think about an impact bond, it's about more than just raising money, raising resources for one specific impactful program. It's also about how you can foster a new mindset, how you can build some capacity that will enable you to make a difference, make impact at scale. So that is what I'm going to tell you a bit about today, is the process from when we started developing the program, how we launched the program, and now how we are taking the program and building forward to actually achieve scale. So in order to do that, let me start up with this beautiful man on the slide you see here. He is the Director of Public Health in Aarhus, and he's one of the visionary people in the city who have said that we need some strong values, we need some strong principles that should guide how we approach health within our municipality. And when they looked at the diabetes challenge, then they said, well, it is one of these areas where we definitely need to do something. And in order to do that, let's look at our starting point to make sure that we approach this in the right way. So the starting point was a triple no. Maybe that's not that encouraging, but it's actually a very, very important starting point, that when they look at the challenge of the rising burden of diabetes, the first thing was that they acknowledged that no, you cannot afford to wait. We definitely need to act now, because the burden will just continue to increase. And if you do nothing, then we are not able to manage the burden when we look forward. So we cannot afford to wait. That was the first insight. The second insight was no, it's actually quite challenging to reduce the burden of diabetes. So we actually don't know how to do it, both in terms of a practical approach, but also in terms of mobilizing the required level of funding for that. But again, we have a lot of experience, we have some competent employees, but we need some new inspiration. What we have now is not enough to defeat diabetes here in our municipality of Aarhus. And then the third thing was that they look at the budgets, and they were facing a lot of different budget constraints. There were lonely people, there were homeless people, there were elderly people with other needs, a lot of different competing needs. So they had to realize that we do not have the sufficient resources to act. But again, they had some good experiences in how to deal with that. They had some initial programs where they look into how they can mobilize funding from other partners as well. So this triple no, it was transformed into something else. I would not say what it was transformed into, but let me just tell you a bit more how we progressed. So when they realized this, what they did was that they launched a big diabetes action plan, and as part of that, they thought, well, this approach, how we look at diabetes, we need to change our whole mindset here. When you look at how you spend resources within the health space in general, you can see that you'll use approximately 3% of the resources on prevention and 97% of your resources on treatment and care. And that's clearly, that doesn't work. That's not sustainable. So what they realized was that they needed to adopt an investment approach to this. They needed to invest much more in prevention. So the first part of that program process was to launch a few small investment programs within different areas, just to test out what it means, how you can create an investment case at a small scale, just kind of a playground to do that. And then based on that experience and the greater diabetes action plan that was launched, they launched this the pilot study, the first diabetes impact bond here in Denmark. It's an impact bond of worth 1.5 million euros approximately, that targets 450 vulnerable people in high risk of developing severe complications due to diabetes. And then based on this pilot program that is running now, they have they said this is so successful, so they decided to move forward and see how can they take this program and take it to scale. So that's where we are now. And maybe just, so let me just see what are the experiences of the process so far. So the first experience here, going back to the triple no's I introduced in the beginning, is that yes, it is possible to construct an investment case for prevention. So this idea of not having the resources to act, now we have a very, very good argument to mobilize the resources, because we have a pretty solid business case that can support that process. When you go to the politician, the decision maker, and say, well, it's not just about helping people, it's also about helping our economy here in the city, you have a better argument. So that is a clear win at this stage. The second thing is that we proved that it was actually possible to reduce the risk of diabetes-related complications with a program like this. And just a few facts. When we started the program up, the expectation was that we could change behavior among 1/3 of the participants. But so far, I think we approached approximately 80% of the people who are enrolled in this program actually adopt a healthier lifestyle and achieve a very significant reduction in their blood sugar. So yes, we can indeed reduce the risk of diabetes-related complications. And then thirdly, this program proved that it is also possible to raise resources among external stakeholders, because they can see that the investment case is solid. They can see that we can actually change the behavior, which would unlock a payment at a later stage. So now we have seen that it is possible to raise more resources for prevention programs, and that is something that the municipality is now working on to see how can they use this capacity, this knowledge, these experiences to make an even bigger impact. So that is where we stand now. Based on the first project, it was 1.5 million. The city council this autumn decided to allocate 15 million euros, which is like at time 10 times as much as the first project, for the establishment of a community health fund, which is dedicated solely to investing in new initiatives that can promote healthy aging within the municipality, including healthy aging among people suffering from diabetes. So this health fund, they have 3 key focus areas. It's about knowledge, about building more knowledge about what are the most impactful interventions, so we can allocate more resources to the most cost-effective interventions. Then it's about building capacity in terms of data and analytical capabilities to say, how do we actually monitor if an intervention is successful or not? How do we make sure that we can mobilize the right partners at the right time? And how can we make sure that we can transform health outcomes into financial savings, is something that we could use as a currency when you're talking with politicians. It's also always very useful to be able to talk the language of economists when you engage in such negotiations. And then finally, it's about building partnerships, because one of the key things, and I think we'll probably come back to that in the discussion afterwards, it is that if you really want to do something at scale, then you need partners. You cannot do it yourself. And this program proved that you can actually engage and mobilize partners if you have the right visionary leaders to kickstart that program. So impact at scale, that is what we are aiming for now in Aarhus, and really looking forward to follow that program and see how it expands. So thank you, Joe.
Thank you very much, Hans. 2 really great presentations that provide really practical insights into what can be, I guess, for some listeners, quite a complex area. And I'm just wondering if I can put my first question to you, Hans. Hearing what Rimke presented and the context that she set out in The Hague, when they first came to Copenhagen in November last year, and now, of course, you've had another opportunity to work with them to understand a little bit about the challenges they face, the setup of the program, and the context. What about the situation in The Hague makes you think that a social impact bond, social investment approach could be appropriate and could make a difference in that setting?
Yeah, I think that Rimke mentioned it in her presentation that they have a lot of good initiatives going on in The Hague. They have a lot of competent partners, but what they don't have is a sustainable business model. So what they need here is they need another tool that they can use to mobilize additional resources for prevention, and they also need a tool to engage your partners in a slightly different way. I think that one of the key learnings from the Aarhus project was that when you start when you invite people in for a conversation, you start talking about the outcomes. You say, well, do we have a common goal here? What is the best strategy to achieve this goal? And then you're forced to think about this economic side of the intervention from the beginning. Then it kind of adds a new flavor into that discussion. And I think in the Aarhus case, it showed that it was very, very productive. These different players that talked in another way, that found new solutions together. And I think that what I'm experiencing in the dialogue, following the dialogue in Hague, is that there's also some new thinking coming up. They're having some new good discussion with the insurance companies, with some of the other stakeholders. And I think that's really, really important. And I think that is what I'm so happy to see progressing in The Hague.
Just a quick follow-up question, then I'll come to you, Rimke. But, I think sometimes we're often thinking about, okay, well, what is the impact of this? I mean, always when we're working in public health, we want to think about what is the impact. But, what are some of the direct sort of population health impact that we might be expecting from this sort of approach, and then how can we think about the replicability of it, sort of taking the lessons from one context to another?
Yeah, so I think that so when I mentioned in the beginning, it was about more than just helping the people that are targeted with the intervention. But of course, the focus of the intervention is to help people in need. And I think that if you look at the Aarhus model, what we have there was that they had a small-scale intervention that was offered to, I think, about 80 people, and they did not have resources for offering this kind of high-end service to more than these 80 people. And with this impact bond, we managed to scale the program with a factor of 5, which means that now we are providing 450 people with access to a very, very impactful health intervention that you can see have a significant impact on the quality of life. And I think when I was in Aarhus with Rimke a few weeks back, we met some of these participants. You could see the change. You could see how this program had made a huge difference for their way of living. And I think that's of course what drives me when I see the programs, and I hope that we'll see something similar in the Netherlands.
Great, thanks very much. And now, Rimke, a chance for you to also put in your own words. I think in your presentation you said, you gave an example of, in many cases you can have a project that lasts for 2 years and then suddenly the funding runs out. And not only is that sad for the project itself, but especially when you're working with the community, you lose trust. So, I mean, you said sustainable financing is a real incentive for you and colleagues to be involved in this. Could you talk from your perspective, which is I think a slightly different perspective from public health perspective, as to the value of approaching this from a business case angle? I mean, what is that a different way of thinking for you, and what sort of benefits do you see from approaching it that way?
Yes, of course, it's different from me because my background is in health science and always more focused on the health outcomes and also the quality of life, the outcomes for the people themselves. But for 4 or 5 years, I work now in The Hague, where we look from more a population health perspective, in which you also take into account costs and also satisfaction of the care people receive, but also from the healthcare providers given care. And I think, we had a sneak preview to the future due to the pandemic that actually our system can't handle a very much increasing health burden. So we really have to look in a different way and also focus on prevention, and also maybe a bit more, I'm used to make a risk stratification, not only looking at the medical determinants, but also the social determinants, and more looking in a not equality way, but equity. So not everyone needs the same level of care, but let's focus on what is needed. And then, of course, if you want people to invest in a sustainable way, then you also need the financial viewpoint. So that was very interesting to hear how the other examples approach this. And it is also very helpful that Hans is involved and helping us, okay, how can you build the business model from another perspective? And of course, I'm used to look interdisciplinary, but it is usually interdisciplinary from medical and social domain. And luckily, I have colleagues who are also experts in alternative payment models. But it's good to have experts who, can tell a bit more about that. Yeah.
Super. And just a follow-up question. I mean, I think this has been a process that's been going on for some time now, various iterations, and a lot of, from what I can see and what I participated in when we had the more recent meeting, is there's a lot of conversations going on and reflections. What have been some of the sort of challenges that you've experienced in throughout, in terms of identifying the population, the interventions, like how to cost the data. I mean, please speak to the challenges that you feel and how you've addressed them as a group.
Yeah, well, I think one of the challenges, I think Hans also slightly referred to that one, is that if you have a new idea, then usually you start with people who are very enthusiastic with innovations, sort of the early adapters. And in this case, with the group consultations, we have a GP who started with this, and she's very dedicated and also really want to improve the health of this population. But if you want to scale up, you need also the laggards or the main majority also to embrace the idea. And I think that is really a challenge. Really have to look, okay, who do we want to convince, and do we have stakeholders who represent them, and not only represent them but also can convince them to work in a different way. Because I think that was one of the challenges we also heard in Aarhus, that there was a representative of the GPs involved in the business case. But then running the project, it was quite difficult to engage. I don't know if it was a he or she, but to engage his or her colleagues. And now we already started with the enthusiastic GP that she engaged her colleagues. And we see already that her colleagues are very much willing to work in a different way. And I think for me, that is very important to see, okay, it's not only a few people who are enthusiastic, but we can convince others to really work differently.
And Hans, how do some of those challenges resonate with you in terms of what you've seen in Aarhus or other settings when trying to think about this?
Yeah, it sounds very familiar. And I think that this challenge of taking one initiative. So we look at Aarhus, you have some very visionary leaders that said, well, we want to go this way. And then I think when we had the first workshop, it was actually a very interesting experience. I think we had, Otto had invited 25 people, all kind of stakeholders in the room, say, I want to go that way. And then after 3 hours of workshop, then he said, well, if there's anyone here in the room who is not really excited about this, they should speak up. So he was not looking for objection, he was looking for, say, are there anyone who is not excited? And I think this is kind of the commitment and the kind of leadership that he showed from the beginning was very, very crucial for the process. Because based on the Aarhus experience, we have here in Denmark, I've been engaged in a dialogue with 6 different municipalities, looking at Aarhus, say, how can we replicate that model? And they're very engaged as well, but there are always some slight challenges. They have their own problems, some small challenges, and then they do not have these municipalities do not have the same kind of leaders necessarily as they had in Aarhus, and that means you always need to adapt it a little bit in order to make it fit. But I think that the experience that we have is a good experience, and it's enough to kickstart the discussion. And then when you have the discussion, as the discussion we're having in the Hague, then when you take the mindset and combine it with the local insight, something magical often happens. And I think this is what is happening in the Hague. Hopefully, fingers crossed. Yeah.
And do you recognize that, Rimke? That sort of excitement, engagement, and is critical.
Yeah, the beginning is a bit, I think the sort of the free nose. Hans also mentioned that every stakeholder is very much looking, okay, no, this is not my responsibility. No, it is important, but someone else has to do it. And really to change that mindset. Okay, now we really together in a partnership want to work on this. And okay, maybe I have to give something and the benefits are not at first for me, but for someone else. I think that is really sort of, well, the struggle you have to go through. And once everyone really embrace it and think, okay, it is okay if not benefits are in the short term for me, then I think, you have a nice business model and a partnership and you can move onward. Yeah.
Good. Thanks so much.
Yeah.
And then Hans, I'm just trying to, for some of those who may have been listening for the first time and still grappling a little bit with what the concept is. what would you think of as some of the first steps in thinking about developing a social investment case? I mean, going right back to basics, like what are some of the things that you need to be thinking about if you were to roll off a recipe in a way? I mean, I know it's a bit more complicated than that, but
but I think it's a good question. Like, you need to simplify it. The first step would be to simplify the narrative slightly, to say, well, and ask yourself one question, and then say, okay, you have two options: either you act or you don't act. And I think that when people they're faced with that question, so what would be the cost of inaction? Then I think that most cities like Aarhus will up and say, well, inaction, that's very, very bad. So we need to act. And then when you have to acknowledge that you need to act, then it's about how to act. And I think you need to move from the should I act to how to act. This is the first thing you need to do. And that question you need to ask not just to yourself, but also to a bigger partner group. And then the second advice would be to make the process as inclusive as possible. When we made the process in Aarhus, as I mentioned before, the director of health invited all stakeholders into the room and asked them that same question. And then everyone said, okay, yeah, inaction, that's very bad. I think that was also what you mentioned before, Rimke. You kind of create an alignment of values and missions by saying, well, we need to act. And then it's kind of people's defenses there are lowered a bit, say, okay, but how can we then do it? And I think this inclusiveness is extremely important. So it's not just some smart consultants, economists sitting in a dark room making a smart investment model. It's about making a process that is truly inclusive from day one. That's extremely important.
That's great. And I think inclusive is a key word that I'm hearing. And Rimke, I mean, from my impressions, the process that you and your colleagues have been trying to work through in The Hague has been very inclusive. You know, it's a very diverse, multidisciplinary team, but also in engaging with the community through the existing program. Could you put a few words to that, like how important that has been for you?
Very important. Of course, as what Hans said, if you really need more stakeholders to be involved, and it is important to include them from the very early beginning, or at least from a moment that they have the feeling, okay, what I say really matters, and changes can be made based on my input. Because usually when you confront people, although maybe the end result would be the same, but it is important for the feeling that the involvement, that it is also that you had a say and a thought about it, and especially for the residents in the neighborhood, that we not talk about them, but really ask them, okay, what matters to you? What's important for you? How can we help you? Because I think a lot of initiatives usually we make from our own perspective and not from the perspective or in a cultural sensitive way. So yeah, I find that really important. So therefore also the meeting in January was very nice, that there were residents present and also people who worked with them on other programs, who really said, okay, yeah, what you thought about in the masterclass is, yeah, it makes sense. We also feel that. And of course, there were slight differences, putting the emphasis a bit more on one outcome than the other. But I think it was important to engage them already. And therefore, the meeting we will have at the end of the week is also important, because then you can discuss, okay, this is where we are now. How do you think about this? What are your thoughts? How can we move onward? So that's, and of course, it needs to be done at the moment where adjustments are still possible.
Hans wanted to.
Yeah, it's just an additional comment. When I mentioned this inclusive process from the beginning, actually at when we started the process up, we did not invite the people, the citizens, into the room. But I think that when we start to design the intervention, to say, okay, how should the intervention look like? Then we very much included the participants and say, well, we had this idea that we should work with the participant in this and that way. We had a very clear perception of what would be the key ingredients, but this mix of ingredients needed to be mixed in slightly different ways for these different target groups. And then that implied that we were, with this model, we had the flexibility to adjust the intervention, to make some new material, to make a more, in order to, as Rimke mentioned earlier, that to manage the fact that some people are not able to read, some of them are not able to understand the diagram. They need other kind of means of communication. And I think that flexibility in the program actually enabled the municipality to create a program that was truly patient-oriented in the way that we looked at the patient and said, what do you need? How can we move you from A to B? And that's also that's demanding, but also very impactful.
Yeah.
Yeah.
And just one thing I picked up on your presentation, I'm paraphrasing, so I'm not sure if I got it correctly, but it sparked my interest. You said something about this field of work, social impact, social investments, not just about addressing a finance gap. It's bigger than that. Could you put a few more words to that? Because I mean, as a public health person who's often been in a situation where we don't have the funds that we need, that's something that's appealing, but maybe you've got a broader perspective on it. You could put a few more.
Yeah, so I think that the general point with that remark was to say, well, it's more than just the project. To say, well, when we developed a project in Aarhus, it was about 450 citizens getting access to a very impactful intervention. Mm-hmm. But based on the learnings from that program, we have launched this new fund, and the municipality has launched a new fund. And what they're using here, and that's the important thing, is they're using the same mindset, the same metrics, the same logic, and that means whenever when you're kickstarting the next discussion, and we had a kickoff on a program yesterday in Aarhus, actually, where it was targeted at people with lung diseases, COPD, and they wanted to adopt the same model, but they were not starting from scratch this time. Now they had the mindset, they had the models, they had the partners in the room, and that meant that now when we build the next program, you start from a much better position than the first program. So it's more than just a program, it's about creating a sustainable change and also unlocking investment in other areas.
Does that resonate with you, Rimke, sort of about the sort of long-term potential of a new way of thinking and long-term potential?
Yeah, and I think also what helped now was that the partnership was already there and the trust within the partner. So you didn't have to build that one. It was there, and then of course you can start at the point that you say, okay, on which population do we want to focus, and build your model from that point onwards. So I think the main starting point, what takes time, is actually to include all the stakeholders, build a partnership which is really sustainable, and then you can move onwards and build several projects, activities for several populations. And also what I noticed, what was really nice, of course, if you start with a smaller group, with the pilot, with the early innovators, enthusiastic people, they are motivated to think about, okay, this material doesn't work for this population. How can we change it so it will work? So therefore, of course, it is important at the beginning that you are with motivated people working on something like this. And then every time, if you want to scale up, of course, you have to make a context adjustment. But once the partnership is there, I think it works well. The process goes a bit faster. Yeah.
And looking to the future, I mean, I think you've been building up, right? There's been a lot of ideas. There's been a process of getting it on paper and out in the community and getting feedback and stuff. what do you see on the horizon in terms of potential challenges that you're reflecting upon? I mean, maybe it's too early to say, but are there things that you've sort of got in the back of your mind, yours or your colleagues' minds, that you're thinking about a lot ahead?
Yeah. Yeah, of course. Well, we are thinking now there are a few possibilities for a more sustainable finance, but we have to see if that works out. But what I really found crucial is that within our area, there's not one main insurance company, so more insurance companies are involved, and there are some changes there. So, and within other stakeholders, there can also be changes in who is leading what. So I think we have to go from one visionary person within an organization who can really make the others say, yes, we want to go forward, to an organization who says, yes, we want to go forward. So it is not only because this person who works there says yes. So I think that is sort of what I found still a challenge, that it is really the organization. But okay, within the Happy and Healthy The Hague, I think there is a nice fundamental or framework. Yeah.
And could you put a few words from your perspective, working in the Netherlands at the national level? Could you put a few words to your experience coming on a field visit to Denmark to see Tingbjerg, to see Aarhus, also participating in the masterclass where you got exposed to teams from other contexts working, on similar perhaps, but also quite different topics? I mean, how has that inspired you
Well, I think what we all had in common is how to engage a vulnerable population, and that is always a challenge. And I think it is very nice to learn from the others how they approached it, and also to exchange how we do it, and also, of course, it is always, when you look back, then you always think, okay, well, we could have done things differently if we would have had the knowledge we have now. And it is nice if you can hear from projects who are a little bit further, who can really tell, okay, well, these are our learnings. And then, of course, you can think, okay, could this be a possible barrier in our situation? And okay, they approach it this way. Good to bear that in mind. But also, I think the main thing actually how to engage the people. Yeah.
And Hans, you facilitated that masterclass. What did you see as some interesting takeaways from the 4 different cases that were participating?
Yeah, I think that it was very, very productive to have 4 groups gathered together, because they were facing some of the same challenges. And I think just getting an outside-in perspective of some of the challenges that you are facing, it's very productive. And also I think that when you are gathered when you're forced to present your own ideas to others, then you also, if you're not just working one-on-one, then it's one thing. But if you need to stand up and say, this is our case, and present it to another city, then you are forced a bit to be even more explicit on what are the key challenges that you are dealing with. And I think that some of the questions that the groups ask each other also kind of kickstarted some of the discussion, because I have not thought about that. So having more people in the room with different perspectives, with kind of diversity, was very productive, a very good feature of the masterclass, I think. Yeah.
Nice. And then Rimke, you mentioned about the commonality being that everybody was working with vulnerable populations. Do you have any reflections from your experience working with the specific population in The Hague that you're working with that you think are particularly important lessons that you could, others may benefit from if they're working with similar communities?
Well, I think it is similar to the experience in Tingbjerg. Apologies for the pronunciation. So you have to repeat it later on. But that you not the first problem they have is not, oh, I'm unhealthy, or I have a high risk on developing a disease. it is usually more basic. Okay, do I have enough money to feed myself, feed my children, to stay in my house, to stay at home? Often there is distrust for healthcare providers or other people from the municipality. So I think first focus on that. How can we build trust and engagement and show them, okay, we are not here just for 1 year giving you something nice and taking it away after a year, but we will really stay longer here, first work on the things that is important for you. And once that's in place, then you can move onward, also focusing on a healthy lifestyle.
Thank you.
And maybe just one, can I add a comment to that? I think this idea of, say, well, whenever you want to do something impactful within the health area, you also need to take all the social determinants into account. I think that's one very important addition to that. So when you look at the business case for helping vulnerable people manage diabetes, then if you help people manage a disease, then you also help them manage their life in general. And that means when you look at the benefit of a program like that, it's more than just the health outcome. There will be some social outcomes which will also hold a high value to a municipality or region or a nation. So I think it's great to have that in mind, that the holistic approach is essential, both in terms of creating impact, but also in terms of creating a very solid business case.
Yeah. I think rooting everything in the social determinants of health approach is super important. I have one final short question for you, Hans, which is around, can this be applied in low middle income countries? Obviously the NCD crisis, obesity is affecting low middle income countries equally, if not more, than high income countries. So do you see investment case approaches being applicable in low middle income countries?
Yeah, so I think that when you look at the burden of diabetes, then the majority of the burden is being borne by low and middle income countries. So that's a very good question. And I think if you look at the impact, the social impact bond, the development impact bond space, then most programs are in high income countries. But I think there are about 40 programs running right now that are targeted low and middle income countries. So it's definitely possible to use the model in a low and middle income setting. And I actually had the pleasure of being in Armenia a few months back, looking at a potential program. There are some other initiatives going on in other regions of the world. So definitely an interesting model in a low and middle income country setting as well.
Okay, topic for another CCD round.
Yeah.
So thank you very much to our speakers. I'm afraid our time is up. Before we depart, I just have a few final points to bring to your attention. So if you missed a couple of the points and you really want to go back and listen, the full recording will be available at the Cities Changing Diabetes YouTube channel. If you have any questions or think this approach could be relevant to your local setting, please do reach out directly to us at info@citieschangingdiabetes.com and we'll connect you to the relevant speakers and people in my team. We also have a guide to the social impact investments approach, which you can find at www.citieschangingdiabetes.com under our Take Action section. Our next CCD round will take place on the 27th of June, where we'll hear about the Copenhagen-based non-profit organisation Hello Kitchen, which organises cooking courses for vulnerable families in collaboration with Danish municipalities. So thanks again, Rimke, joining us from the Netherlands, and thanks for Hans coming into the studio today. It's been a really fascinating conversation, and I really appreciate the time that you've both taken to be with us today. Have a wonderful day, everyone who's joined, and keep sharing and come back to our next CCD round. Thank you so much.